Hi, my name is Hadija Hussein, and my project was on fall prevention strategies in acute care settings. So I focused on strategies that will collaborate efforts between leadership and staff, encouraging peer-to-peer audits, and provide education and training that is patient-centered, um, in, includes patient-centered fall strategies in the interventions. So, what is fall? Fall is an event that results in an unintentional resting on the ground, floor, or other lower levels. So, fall is an ongoing challenge in hospitals, and it can cause injuries, increase lengths of stay, and increase cost. Approximately 11,000 patients die in hospitals due to falls with injuries, and that's from Roshan and Salazar 2019. So hospitals need to find ways to reduce falls so that we can save costs and have better patient outcome. So I was looking at the implications of fall economically. It's financially draining to the healthcare system, and also it affects patients' earning capacity, because once somebody falls and they become disabled, they're not able to provide for themselves. Socially, falls can result in serious long-term injuries that can affect the quality of life, and it can also increase isolation and also cause caregiver burden. Ethically, when we consider fall prevention strategies in hospitals, sometimes we have put patients in one category. Even somebody who's alerted oriented, we still give them a high score based on what's going on with the patient. And you place the beta alarm on, and that can be stressful to that patient, and they feel like they don't have power, even though they don't want the beta alarm on. We still put it on so that we can prevent the fall. So that's it reduces the patient's sense of autonomy. So in order for us to come up with the solution for reducing fall prevention, we have to use a SWOT analysis, which is strength, weakness, opportunities, and strengths. So the strength that I was able to look into is we have the most fall risk score that scores the patient and tells us what interventions the patient needs to have while they're in the hospital. So that's a strength. And we also can use patient safety monitors when we don't have, when we're trying to use interventions that already are in place and it's not working. So instead of putting a patient on a restraint, we probably have somebody at the bedside to watch the patient. And also we have equipment such as bed alarms and side rails. So once you have the side rails up for patients who don't have the strength to get up, it's helpful. And when you have a bed alarm on, so by the time the bed alarm is coming on, it's easier for somebody to run after and catch the patient before they fall. The weaknesses that I've been able to see is non-compliance on fall prevention strategies with the staff. So either the staff is tired, or they forget to put the bed alarm on, or they implement one part of the intervention and forget to do the other part. Either they forget to put socks on the patient, that's non-slippery socks, or they forget to put a handband on. That indicates that this patient is a high risk for fall patient. Also, when we have shortage of staffing, that can create a weakness also, because when the staff has so many people to watch at one time, they don't have enough time to target the patients who are high risk for fall. Another thing that I was able to see is lack of education. So this goes on both sides. Sometimes it's the patient side. If they don't know that they are high risk for fall and they need to use the call light or they need to stay in bed until the help comes, then they tend to get up and fall. And also, when you look at the nursing aspect, lack of education in with nurses also, uh, and it goes to making sure that when you're creating interventions, they are more patient-centered. Not everybody's high score risk score means that they have to have bed alarm on. It could be another tool that you can use to help that patient or prevent that patient from falling. The opportunities that I was able to look into is having mandatory continuing education to keep our staff up to date with current evidence-based practices. We can use video monitoring system because sometimes using the patient safety monitor can be costly. So we can use video monitoring systems to monitor the patients and have somebody call us before the patient starts to get up out of bed. And also try to assign nurses patient in zone closer to their patient. That way a nurse can stay in one particular area and it will be easier for them to run quickly to tend to their patients. The threats that I was able to look into is compassionate fatigue. So once people or nurses or techs are overwhelmed and they're tired, sometimes they tend to just, say, okay, I'll get to it or what, because I'm just too tired. So they tend to disregard the alarms because they're just too tired to deal with it. Another threat is polypharmacy. Having, especially the older population, they have a lot of medications they're taking, so having the combination of medication can increase their risk for fall. So it's important for the pharmacies and the doctors to look into the medication and see which ones they can hold for a while the patient is in the hospital. The rooms also are small and cluttered. So if we can have try to declutter the rooms and take the items that we're not using at that particular time, that will be helpful to reduce the threats. So I used CINAHL Plus to find my literature for this project, and I was able to get very good studies. Most of the studies suggest that we should not use one size fits all strategy to create intervention for patients. The studies also encourage using of cutting edge technologies to help us in creating fall prevention strategies. Also, some of them encourage using collaboration between leaders and staff. This is so that the staff can feel empowered and feel like they have a say towards the interventions they're creating. So they are more at liberty um, to own the project or to own the change. Leadership theory that I looked into was participatory leadership and transformational leadership. They're both leaderships that can help uh, create change. Participatory leadership strives to include staff in the decision-making process towards change. While when you look at transformational leadership, it does a little bit more than the participatory leadership. It motivates staff to reach their potential and also see what they're providing, how that fits into the organizational mission. So the perfect fit that I was able to see is we have to have a balance between the two leaderships, participatory and transformational leadership, so that we can have a better change and a better implementation of the new fall risk strategies. And also would encourage using of shared governance as a great tool for staff engagement. change here that I was able to look into was the Lewin theory that has three phases: the unfreeze, movement, and the refreeze phase. So unfreeze phase identified the need to change and also stimulate positive mind towards change. In the movement phase, this is when you identify the change in the plan, you implement the strategies, and look for barriers to those changes. And when you come to the refreeze, this is when you ingrain the new changes into the daily practice as a new norm. The timeline for the change, the first week, I considered leadership communicating the need for change, for changes. So the second week, we have staff and leadership roundtable where everybody can voice their opinion and provide solutions to what needs to change to make the project successful. Week 3 and 4 will be more of training, computer-based learning, teaching about patient-centered care, and how to do peer-to-peer audits. On the other side, also, we have to make sure that we are training the clerks and then certified nurse assistants on how to report on and documenting malfunctioning equipment, such as bed alarms. Week 4 and through 8, this is when we will implement, establish fall champions, and encourage feedback from staff. At the same time, we will be tracking the performance of the new change. Week 9, we'll spend that time analyzing the project performance and see if it's successful. So if it's successful, we will celebrate, maybe by having pizza for the staff or ice cream day for the staff to celebrate the success that we have had. If we didn't, then we circle back to training and see where we can change and also get staff input. Evaluation, I looked at it in terms of quantitative data, which will be assessing staff level of acceptance and commitment. So just to see how staff is agreeing with the new changes and what needs to be tweaked if there's anything that is not, they don't feel comfortable with. And then also we'll look at qualitative data analysis. So that will be, we'll compare the fall rates before and after the change was implemented. Project success means we will have low fall rates and also we will have employee positive outlook about the change. If the employees are not buying into the change, then maybe the first couple of weeks we will do well, but then they will stop doing what they're supposed to do. So we have to make sure that also we have the positive outlook from the employee side. The unit conclusion, I can say that if we implement the changes, the unit can decrease the fall rates by using the evidence-based studies, incorporating patient-centered fall interventions, enhancing training as needed and mandatory also, encouraging collaboration among staff, managers, patients, and caregivers, meaning getting feedback from the patients themselves, their key caregivers, and staff and managers. And this is some of the references that I was able to use for this project. Thank you.